So I'm Matthew Harris. I'm a clinical senior lecturer in public health medicine at Imperial College London. In that role, I'm theme lead for innovation and evaluation within the Northwest London NIHR Applied Research Collaborative. I'm also director of postgraduate taught programs within the School of Public Health, and I'm an honorary consultant in public health medicine in the NHS, in the Imperial College Healthcare Trust. But I've come to this work, I think, very much from a global health background. So even though I'm born and bred in the UK, trained here, I very early on in my career moved to Brazil and worked as a family doctor in their primary healthcare system for several years, having requalified in medicine in Portuguese in that country. I know that was not for the faint-hearted, I have to be honest. Nevertheless, that sort of very much shaped the rest of my journey, funnily enough, because having worked in primary care there, I then moved to Ethiopia, worked for the WHO for a bit in immunization programs, and then in Mozambique, running some HIV programs in central Mozambique and Shimoyo, and became really very inspired, I think, by the amount of innovation, skills, capacity, ingenuity that was happening in very resource poor contexts such as those. And when I returned back to the UK, pursued a PhD and became a public health consultant in the NHS, realized that there was really just an awful lot that we can learn from those settings, and we just sort of weren't doing that very much. So fast forward 20 years, I sort of developed a bit of a corpus, I suppose, of research in that space, and the book, which I'll speak to, sort of summarizes, I hope, a lot of the thinking that I and colleagues have been going through over the last several years, which is sort of all about identifying low-cost solutions from resource-poor settings and seeing how we can adopt them where the opportunities are here in the NHS to save money without scrimping on safety or effectiveness, whilst at the same time addressing some of the imbalances in global knowledge dynamics, let's put it that way, which I can get into. So that's a very, very whistle-stop tour of my background there, Matt. But this is a very small group. I have slides which I would speak to, and we can start with that if you like, and then power through them, and sort of hopefully that might give an opportunity for colleagues to think of aspects that we might want to drill into in a bit more detail, perhaps have a dialogue about what some of the issues are that's raised. Be very happy to do that. So, Matt, are you happy for me to just...
Please do. And I think we should add that you've had a National Clinical Impact Award for your work in bringing in frugal innovation. So that we'll mention that on your behalf.
Oh, that's very kind. I did forget to mention that, but that was very recent development. So still, let me see. Are you seeing?
Yeah, it's coming up, I think. Yeah.
Oh no, now I think you're seeing the wrong bit. I'm not sure actually. Hang on. Let me just see something. One sec. Sorry. There we go. Is that working?
Yeah, that's good.
Okay. All right. Well, thank you again. I mean, I'm going to just sort of zip through a few slides in sort of 25 minutes or so, and then open up for maybe some conversation. I'm structuring the presentation, I think, into 3 sections. So the first, I'm just going to look at some, I think, really notable examples of low-cost solutions from low-income countries and some of the rationale for what we should be doing in the UK around these. And they're coming from a variety of different clinical disciplines, ranging from orthopedics to plastic surgery, neonatal medicine, and others. Then I'm going to be looking at some of what the issues are around adopting those sorts of solutions, both specific to those solutions and also more general. And then wrap up by considering what some of the ways forward might be to address some of those issues. So I'm going to start with just a smattering of examples that we're aware of. Some of you may have, Kerry, probably you've already heard of this, and others perhaps, but the GE Mac 400 is a low-cost alternative to an ECG machine. In the UK, we spend upwards of £10,000 on ECG machines that are generally sort of ward-based, on trolleys. They're quite big, bulky, quite sophisticated as well, with sort of displays and other things, and oftentimes in ITU, they can be even more expensive than that, I think. So the Indian subsidiary of GE Mac 400 in the 90s was actually tasked with developing an alternative to this type of technology where it wasn't available in those sorts of settings. And they came up with this very lightweight, affordable, very affordable, in fact, it's only a few $100s ECG machine that you can put in your satchel. And it spits out the 12-lead ECG, you know, of just as good quality as the more sophisticated technologies that we're using here in the UK, and is now being marketed in the US and Sweden and many other countries because it's improving, of course, in addition to cost, it's improving access to cardiological diagnostics because it can be used in remote areas or, you know, in outpatients or in clinics and GP practices and so on, by virtue of being much more affordable. And it being now used in some of these high-income contexts is notably referred to as a reverse innovation, which we'll come back to in a little bit in terms of the terminology. Another example, this time in orthopedic surgery, this is called the Arbutus drill cover device, which was developed in Malawi and Uganda, in fact, with orthopedic surgeons there in partnership with Canadian bioengineers. In the UK, again, some of you might be aware, but in the UK, we use these very expensive drills that are stainless steel encased. They can be called Stryker drills made by Stryker or other companies. And they each cost around £30,000 because they can be autoclaved in their entirety. You take out the battery pack at the bottom and you can put the whole thing in an autoclave to sterilize it. So when you come to an orthopedic operation, you can drill a hole without risk of infection. But that actually is what makes it very expensive in part. In Malawi and Uganda, they had been using ordinary hardware drills in the bottom screen, which of course are not sterile, but were wrapping it in sterile cloth and using that in orthopedic surgery. And the Canadian biomedical engineers observed that technique and improved on it in the process of co-design with the orthopedic surgeons, creating from the cloth a fit for purpose, if you like, bag made of the same cloth material that the drill can just be inserted into, rendering that drill sterile, essentially, because it's encased in now this cloth bag. Now, the cloth bag is really very cheap. It can be used up to 75, 80 times before it starts to deteriorate. We actually published a paper in BMJ Innovations that looked at what we might be saving if we were to use this device in the whole of the UK compared to the Stryker drill. And it was something like £100 million we would save if we swapped out everything overnight. And at trust level or hospital level, thinking about the number of operating theatres that on average a hospital might have, they would save upwards of £230,000 per annum. Now, we know that things don't get swapped out overnight in this way, but nevertheless, it builds a sort of a strong case for attention to technologies such as this, because that's an awful lot of nurses, for example, that we could be employing for the amount of money that's being saved for this device. And studies have shown that there's literally no difference in infection rates, which would be the main concern here, or feasibility or acceptability of use of the technology in terms of clinician appetite and other things. So, you know, there's a strong case for it. Now, in the case of neonatal medicine, ordinarily what we would use in the case of premature birth or preterm birth, babies would be at risk of hypoxic brain damage oftentimes. And one of the mainstays of treatment is called therapeutic hypothermia, so to reduce the body temperature of the neonate as quickly as possible, as safely as possible, so down to about 33.5 or 34 degrees. And that preserves the brain tissue in that hypoxic moment. Now, those incubators almost, they're like reverse incubators, are quite expensive, costing between £20,000 and £30,000 each, obviously only therefore available in NICUs, in neonatal intensive care units. Now, in India, they developed a device called Mirror Cradle, which uses phase change material, essentially the same material that firemen use in their jackets, that absorbs heat. So the more mattresses that the baby sits on, the quicker and more significant the heat exchange happens, and the baby's body temperature gets reduced to more or less the same amount, 34 degrees, in a safe and controlled way, requiring no electricity, can be used in a portable manner by nearly anyone. So very interesting device for example, early access, immediate access to therapeutic hypothermia, particularly in remote or rural regions, of course, which we have here in England and Scotland, for example. So there's a strong case for its use. Even in neurosurgery, we can use micro dissection devices, which here in the UK can cost each one 100, £150. They're just made of stainless steel. But actually, Jar, who's a neurosurgeon in India, published a piece of his own experience based on fashioning exactly the same functionality from stainless steel wire, hammered into a wooden handle, right? Which of course you can then sterilize and and adapt the ends of the wire to whatever function you need in that micro dissection environment. And he found this gave exactly the same sort of functionality as the commercial devices that we would ordinarily use. In general surgery, anybody who's had a hernia will know that we often treat inguinal hernias with mesh, commercial mesh made of polypropylene or polyethylene, and usually to great effect. But each segment, which comes in a pre-sterilized single-use only sort of package and it's commercially available, is about 100 to 150 pounds each here in the NHS. And it turns out that mosquito nets, when not insecticide treated, are made of almost exactly the same material. We actually published a piece again in BMJ Innovations that showed that it's actually the mosquito nets are closer in terms of their tensile strength, their flexibility and porosity and other things to the abdominal wall muscle than commercial meshes. But randomized controlled trials have shown that there's no difference in outcomes between using mosquito nets and commercial mesh in terms of infection rates, adverse events, relapse rates, recurrence, etc., etc. Now, you can, for a single mosquito net, probably fashion upwards of 1,000 individually tailored and sized pieces of mesh for use. So for the price of one mosquito net, you could actually operate on thousands of people. So we're looking at a 10,000-fold more or less differential in the unit cost of the mesh when you use mosquito nets compared to commercial mesh, which again suggests that we have an interesting rationale for its use. Saiba's method is in the case of postpartum hemorrhage. So this potentially life-threatening condition, postpartum periods, usually treated medically with oxytocin and other drugs, but when refractory to that, may have to go directly to the theatre for a hysterectomy. The in-between phase can be managed with a balloon tamponade device, such as those that we see in the picture on the left-hand side, which essentially you inflate inside the uterus with saline, and it exerts pressure on the inside of the uterus and therefore stopping the hemorrhaging very effectively. In Bangladesh, Saiba Akhtar is an obstetrician who simply uses a condom tied to the end of a catheter, both of which are readily available, both of which are cheap as chips and 200 times less expensive than the commercially available devices, with no difference whatsoever in outcomes. In fact, slight improvements in outcomes in terms of mortality, according to Suarez's systematic review. Tilapia fish skin, just my final example, is in the case of plastic surgery, is really interesting. When you suffer a second or third degree burn, you've got some options. You can have a skin graft from your own body, which is quite painful and actually, difficult in itself to treat because you've then now got a new wound area. You can have porcine, pig skin grafts. You can have cadaveric, so from cadavers, skin grafts, both of which are very expensive. And some people will have religious reasons why they can't use pig skin grafts as well. There's also a risk of disease transmission with pig skin grafts. In the NHS, we're now more recently starting to use acellular bioengineered fish skin matrix, which is extremely expensive. It's about £1,000 for a segment about the size of your iPhone, which is used as a graft as well in these instances, but very, very expensive. Now, in Brazil, they've been using tilapia fish, the natural fish skin, which is a byproduct of eating the fish, sterilize it, and just place it on top of the wound and wait for it to dry out over the course of a week, and find that actually it leads to equivalent re-epithelialization that you would expect with similar wounds being treated by skin grafts or the other alternative technologies that I mentioned. There's reduced infection, hospital stay, and pain because there's no requirement for redoing the wound dressing. The skin serves both as an occlusive wound dressing as well as a skin graft matrix. So again, really interesting alternatives to the existing technologies that we're using here in the UK. And all of this is really just sort of speaking to this idea of frugal healthcare innovation. These are sort of what happens when we innovate under resource constraints, where we develop solutions that can be really rather ingenious. leveraging existing technologies for a new purpose, or adapting a technology that already exists in another sort of form, simplifying models of care, making something more lightweight or more rugged, making them more affordable. These are all the sort of the features of frugal innovations. A frugal innovation doesn't have to have all of these core competencies, but it just helps as a framework to understand that a frugal innovation is essentially something that isn't lower quality compared to what we're doing. It's exactly the same. There's no scrimping on quality or safety or effectiveness, but it's all being done at a far lower cost through the use of sustainable models of care or design or resources or equipment or other such things, which can all be translated into a value proposition that's much more affordable for the healthcare system. But one of the problems, other than the specific challenges of adopting these technologies, each of which will have its own regulatory and commercial and cost and everything else challenges for adoption, one of the main challenges I think that we have in this situation is that our gaze collectively as a community clinically here in the UK is predominantly towards the West. So looking at some really important policy reports, we can sort of actually identify that the same sorts of countries are always being referred to all the time in terms of comparing outputs or effectiveness or efficiencies with our UK context. Take this report by Wanless in 2002, I think it was. Only France, Germany, Netherlands, Sweden, Australia, Canada, New Zealand were mentioned by way of comparison to the UK. Similarly, the long-term plan, more recently, Germany, France, Sweden, Norway, Canada, the same sorts of countries, essentially Western sort of North American, European countries were the only ones that were ever acknowledged or referred to in these reports. And even in the US, you can see this happening as well. The Commonwealth Fund puts out international comparative studies. And again, the same 12 or so countries are used year on year for these health system comparisons. And you start to wonder that this is when you look at this through the lens of sort of a textual analysis, which is where we view texts as symbolic of how we behave in a society. So how are these reflecting attitudes or beliefs or norms? You start to sort of wonder that these are countries, that there's only ever certain countries that are ever included in the way we think internationally, but also importantly, something called ex-nomination, which means there's no apparent need to justify it. It just sort of is. It's just accepted. It's a norm. It's just what we do. It's just one of those things. And I, by way of comparison, it's a silly example, but I like to draw on this example just to sort of ram home the point. If ever you've seen photos of watches anywhere, on the tube, on the buses, on the subway, in magazines, wherever it is, they just always tell the same time. There's no rhyme or reason to it. There's no policy that's mandating watch manufacturers to only advertise watches showing the same time. It just is. And I feel that the way we pay attention to Western countries only is also in a similar sort of phenomenon. It just is. It's just something we do. I mean, it's so entrenched actually in this case that you have to understand why is it that it's even translating into the mobile phone images. You could argue that as an aesthetic, with a manual watch, it's aesthetically sensible because it looks like a tick, or you can see the brand and the logo. But why then on mobile phones as well? It just doesn't seem to make sense. And you see this sort of continuing and perpetuating, and it's almost quite hard to break free from it. In fact, if you try to doing what's called a commutation test, where you try to reverse or look at a different type of image, in this case, you'd suddenly think, well, it's something not right about the photo. There's something, I can't put my finger on it, but there's something not right about the photo. And it's probably because we're just so used to photos showing 8 minutes or 9 minutes past 10 that when it doesn't, it just sort of doesn't look right. Now we can tie this in very well also back into our questions around the gaze that we have towards the West. So, for example, in these reports that I showed you earlier, there were very, very few reasons provided as to why these countries were being selected beyond other types. In fact, in this report, I could only find one reason, one explanation as to why these countries were selected, and it was to do with the fact that these countries at the time of publishing had broadly similar levels of income per head of population. Well, on that logic, the Faroe Islands, Greenland, Guam, and Puerto Rico, who also at that time had the similar levels of income head per population, could also have been included. but they weren't. And had they been, we probably would have felt a bit like with the previous watch photo, a bit like, oh, why are we comparing ourselves to Puerto Rico? We've never done that before. So it would feel a bit odd in this case mutation test. Similarly, with the long-term plan, there was only one instance where there was an explanation, a justification for why one country was being compared to the UK in this report. And in this instance, it was in the case of looking at leg amputation rates, where the UK was compared with Germany, which had at the time twice the rate of leg amputation. But at that time, KwaZulu-Natal also had twice the rate of leg amputation as the UK. Why wasn't that chosen as a comparator? There seems to be some sort of structuring in the choice of countries that we will pay attention to. Similarly, in the Commonwealth funds, again, only two reasons given in the entire report as to methodologically why these countries were selected for comparison: the dollar spent on health per capita and the percentage GDP per capita on health. But at the time of publishing, Cuba could have been a perfectly valid comparator country based on that logic. Uruguay, Suriname, South Africa, and Sierra Leone as well. But they just weren't. It just feels like it's something we just don't do. It's like there's a league of countries that we compare ourselves to, and other countries just don't seem to fit into that norm. And I think there's a lot of heuristics, mental shortcuts that are happening in this space. So, for example, when we asked US health policymakers which countries they pay attention to and the reasons why, they uniformly would answer, well, Canada. Why? Because it just feels more similar to us. You know, the schools seem similar. People have been, we speak the same language, you know, the media represented in the media in a similar sort of way. We can sort of feel that it's probably got the same sort of active ingredients that make it similar to the US. But I would argue that this is a mental shortcut because it's actually extremely complicated to determine or discern whether one country is or isn't similar to another country. Let me give you this example by Irene Papanikolaou, published in 2018. This wasn't the purpose of their paper at all, but they were looking at the structural differences and similarities between different countries based on a wide variety of panel data on workforce structural capacity, on population demographics, on population health needs, a variety of different things. Two things of note. The first is that they, again, only included the countries that I mentioned earlier, right? The same sort of dozen OECD sort of Western North American countries, as you can see. The second thing of note is that there is no discernible trend between one country being similar to another country on these parameters. Canada might be similar to Sweden on one parameter, but vastly different to Sweden on another parameter, and so on and so forth. There is no logic that one can reliably say that justifies saying one country is or isn't similar to another country. We are all equally different and all equally the same at the same time. It's paradoxical. So the conscious or subconscious choice to focus only on certain tribe or league of nations over others is rooted in a sort of a sociological phenomenon, I think, that there's just something that we do. We don't pay much attention to the reason why. It's a little bit sloppy, but we don't argue, we don't really question it particularly well. I think there's sort of a structuring in our global knowledge economy that doesn't help. So this is a piece of work that was done 10 years ago now by Pan, published in Scientific Reports, that looked at the number of citations that countries have for their research that they produce. And you can see immediately that there's a global skew, yeah, with global north, let's call it, being vastly more represented. I'm not going to say overrepresented because it depends on how much research is being produced by these countries, but vastly more represented in terms of their citation count. So we're consuming much more from those countries than from many other regions of the world, the Latin American countries, the African countries, and Southeast Asia. Now, this is going to be a function of the way in which the world is structured, right? The resources are distributed, unequally around the world, which means some countries are more able to produce more research, possibly even of high quality research. But it also means that there is a skewing because this is an unlevel playing field. Science is published in English, it's expensive to do it, it's expensive to publish it. And because we are consuming more research from these regions than others, we are living, therefore, in an echo chamber. That means that the more we pay attention to research from these countries, the more we think only research really comes from those countries. So all these other regions are rendered virtually invisible to our gaze because we're just not consuming research from those settings. And it's not to say that those settings aren't producing good quality research. We just don't see it. The way in which some countries are represented in the media, I think, is probably perpetuating a lot of this structuration of the way in which we pay attention to innovations from around the world. And it's represented, I think, beautifully in the very term reverse innovation that I mentioned right at the beginning. Because what reverse innovation means when you're adopting an innovation from a low-income country to a high-income country, essentially perpetuating the myth that innovation normally flows north to south. So when you're seeing it going from south to north, that's a reversal of the norm. We should just be calling it learning or adoption or something that has no valence to it. But we do give it valence because we have an entrenched belief that West is best. Now, I mentioned that I worked as a GP in Brazil for many years. And over the last 20 years, so inspired by their model of primary care, I've been advocating for many, many years with many colleagues as well to bring their community health and wellbeing worker role into the United Kingdom because we have an awful lot of reasons to benefit from it. I won't go into the details of the role itself, but it can easily address at scale widening and entrenched health inequalities, the workforce crisis, social determinants of health, fragmented and expensive care that we have in the UK. And Brazil has had extraordinary results with respect to the scaling of their community health and wellbeing worker role. Now with 250,000 of them in the entire country, covering 75% of the population with proactive, comprehensive household level support by lay people that live in those areas. Okay, so we don't have a role like that until quite recently, which I'll touch on. But over the last 20 years, whilst advocating for this learning to take place, we came up against pretty consistent narratives, only some of which are represented here, about just how weird that is for us here in the UK to learn from Brazil. Coming down really to this sort of idea that Brazil is a developing country, does it even have a health system, or fairly pejorative stereotypes around Brazil just being filled with very friendly people who love community stuff, and so therefore it's going to work there, but it's different here. We're special, it's different, it wouldn't work. None of this really helps in this journey to identify an innovation which is proven in Brazil over 30 years to be extremely effective, and for which we have an awful lot to learn and to stand to gain from actually adopting. So these sorts of attitudes, perceptions, beliefs, stereotypes, prejudices, I'd even argue, really, really delay the translation of learning from a low-income country into a high-income country. This is a case in point. Over and above the ordinary difficulties we have anyway in adoption of any innovation from one country to the next. Happily, in the last couple of years, with colleagues like Connie Jungens and Saul Kaufman and Donna Chapman, who many of you might know more in your area towards Cornwall, we've actually been now recently scaling post-COVID the community health worker role throughout the country, now in 25 different localities. Mentioned in the Fuller Stocktate report, shortlisted for several awards, visits from the House of Lords Committee for the Future of Primary Care, mentioned in their inquiry, and now expanding throughout Westminster with a cluster randomized controlled trial on the cards. It just goes to show that if we didn't have these prejudices in place for the last 20 years, maybe we could have actually had this work start 15 years ago and in place, like they have in Brazil, whilst we entered the COVID pandemic, which would have provided many of the solutions that we struggled to solve when the COVID pandemic started. Better late than never, but it's still, it had been a problem. In just the last few minutes, Matt, I just want to take you through just some suggestions about how we can spot some of these things in our everyday practice. Because I think that there's this sort of pervasive, as a result of many of the issues I've mentioned, there's sort of this pervasive us and them narrative, I think, between rich and poor countries, which is just simply unhelpful. This is the conclusion from one of the randomized controlled trials that published in the New England Journal, that looked at, in a randomized way, the use of commercial mesh and mosquito net mesh for inguinal hernia repair. And in that study found no difference in clinical outcomes or adverse events or infection rates. It's interesting that their conclusion, despite there being no difference, non-inferiority, complete parity in terms of outcomes, that the recommendation for the use of mosquito nets was only for the resource poor settings, which I think is, emblematic of this idea that if it's a cheap innovation, it should be used for poor countries. It's rooted in the same sort of sentiment that I think is explaining a lot of the dynamics that I've been mentioning. Another issue that again is just worth sort of surfacing when you read papers and when you interact with other people is this idea of attribution. In the case of the Saibas device, it's been around for 20 years, but it's only ever referred to as a condom-loaded catheter. Even though it's been patented by Dr. Saib Akhtar as the Saiba method, it's only ever, in all the papers that compare that method to the commercial device, only ever referred to as a condom-loaded catheter. I just think that's noteworthy because it's not like in surgery or obstetrics we shy away from eponymous, syndromes or technologies, giving people's names to technology. We actually really bang into it, in fact. You've got the Seng Stack and Blackmore tube by Arthur Blackmore. You've got the Foley catheter. You've got the Chamberlain forceps, the Leverett forceps, the Keelan forceps, even the Pfannenstiel incision. Many of you will be familiar with them. But when, of course, Dr. Saib Akhtar from Bangladesh invents something, it's only referred to as a condom catheter device. There's no attribution. But the other thing that I think is really important is the narrative that we create. Saiba's device, the condom tied to the catheter, came first. It was being used in Bangladesh several years before the balloon catheter devices, which we could look at as an over-engineered solution to what was already being used, hit the market. And we often see with the balloon tamponade devices, the expensive commercial devices, it's always referred to as where places can't afford them, then we should use condom catheter. But actually, the condom catheter device working perfectly fine. We don't need an over-engineered solution such as these. In actual fact, if you dig deeper into the detail, the Gates Foundation are now selling simply condoms tied to catheters back to doctors in Bangladesh from where it already originated, selling it for $5, as if they're doing something good. Now, one has to really ask, if we had a level playing field in terms of intellectual property, in terms of attribution, in terms of giving credit where there was ingenuity, we wouldn't be seeing that happen. We would be giving its due credence and due acknowledgement and recognition to the ingenuity, simple as it might be, of tying a condom to a catheter and showing that it's as effective as any other alternative. You can actually, a lot of what I've been talking about right now is slightly circumstantial, right, to sort of make the point. But actually, there are studies that we've done that actually measure the problem. So, for example, we've done implicit association tests. Some of you may be familiar with these that actually look at how likely you are to associate high-income countries with good research and low-income countries with bad research. And this graph is simply showing the skew, normal distribution to the right, shows that on average, Imperial College researchers actually associate unconsciously high-income countries with good research and low-income countries with bad research. Okay, and so you have to ask yourself, is that playing out in practice in terms of that unconscious association? We've actually looked at that as well, and we did a randomized controlled study online that invited English clinicians to rate research abstracts on 2 occasions, changing the author affiliation from a rich to a poor country, and vice versa. The same person rating the same research abstract, identical content, just changing the author affiliation's geography. Now, all things being equal, you'd expect there to be no difference in the rating of that abstract, but on strength of evidence, relevance to that reader, and the likelihood to recommend the research, on every measure, there was a significant improvement if that abstract was listed as coming from a high-income country compared to the low-income countries, which proves that we're not very scientific when it comes to rating science. And we've proved that scientifically. So, one has to therefore pay attention to the fact that these trends, these dynamics globally in terms of our knowledge economy, the way in which we consume research, the way in which research is published, it is structuring our response to them. And you're entering into this vicious circle where we need a sort of a generational reflection on where we're paying attention to and the reasons why. So, touching very, very quickly on the fact that this is all really down to the fact that modern medicine is in fact a colonial construct. It's very difficult to disentangle our modern medical institutions, universities, hospitals, the medical establishment, from its emergence as part of a colonial enterprise in the Middle Ages and beyond, where plague eradication efforts, disease eradication efforts, all missionary medicine, all took place at the time of colonial expansion from Europe into South America and, of course, Africa and Southeast Asia. So we are, if you like, already have baked in norms, beliefs, attitudes. We might not appreciate it or realize it, but of Europe and the West as being the norm and everything else as being other. Victor Ray, I think, produces a really elegant synthesis of two challenging research areas that haven't been particularly well integrated, which the first is around organizational theory and how organizations behave, and the second is around race studies and study of racism. It's not the case that we're being racist to individuals, for example, by discounting their research and innovation, but we are probably thinking of the institutions from where they're originating and the innovations from where the organizations from where those innovations are originating in a racialized way. We're viewing the University of Mzuzu in Malawi as outside of the norm. We're viewing it essentially as a black organization, even if the people in there might not all be black, but we're viewing it as a black organization. And we view the University of Harvard as a white organization. And that structures the way in which we then respond to the research that those countries produce, both positively and negatively, but erroneously at times, inaccurately at times. We sometimes, therefore, discounting research and innovation prematurely. Final slide, Matt, is just around what we can do about this. We can do soft reform and radical reform. So examples of soft reform is some work that we've been doing in Imperial College, where we convert our reading lists that we give to our postgraduate students into machine readable code that we can then plot on a map so that educators can, at a glance, work out not what they're teaching or how they're teaching or how good their teaching is, but where are they teaching from? What are their sources? What are their influences? And then begin to ask, I think, some important reflexive questions about, is that picture fair? Is it what they were expecting? Should they do something about it in order to increase the diversity of knowledge sources? Do they think that other countries ought to be better represented or not? It's really down to the educator to decide that, each subject being very different. Reciprocal innovation, as opposed to reverse innovation, is probably a much more beneficial way of looking at international health partnerships and how we should share learning between countries, co-developing innovations in two entirely different or even similar contexts, depending how you look at it, one rich, one poor, however you might want to look at it, co-developing solutions that actually meet the needs of both populations and actually seeking to adopt those in the same sort of way, moving away from traditional models of directive, West is best, providing solutions to global South countries. And we provided, for that, I'm sure Kerry is familiar with this, the Innovation Toolkit for Health Partnerships, which is it's a framework, it's a structure, it's an opportunity to reflect on how to engage in health partnerships in a more equitable and balanced fashion. Even in the clinical environment, we can actually apply a decolonial lens. So Sarah Wong and Faye Gish and Amali Gamagi at UCL done a lot of work looking at applying a decolonial lens throughout the medical curriculum. So you're moving away from biomedical hegemony to a more epistemically plural, culturally safe, critically conscious way of teaching medical students that embraces diversity, embraces other ways of thinking, other ways of knowing, right from the get-go, not slavishly applying biomedical lens only. And this, as you know, and others, this is all summarized, hopefully in a bit more detail in my book, which you're very welcome to obtain from whichever your preferred source of books are. Thanks, Matt.
No, thank you. That's a very thought-provoking and fascinating summary of. And I came across your book and read it, and as you say, it goes into a lot more detail, but it just sort of resonated in quantifying things I'd seen and sort of knew were there, but hadn't quite ever fully grasped, and that's through particularly being fortunate enough to work across in Kenya and come back to the UK and seen that slight discrepancy in the way that innovation is approached. I've got a few questions, but I'm going to open it up to my colleagues first. Any questions or discussion points that you wanted to bring up?
Can I just say that was an amazing talk. Thank you so much. Matt, I'm going to go and buy your book today. The fastest delivery. But I think it is, yeah, it was so interesting to see, as Matt said, in the visual format, in like a scientific format, how these discrepancies exist, how these the different way of thinking exist. I remember when I want to talk about innovation, and when I'm kind of writing projects or kind of like talking about research designs, about comparison. When we think of comparison, it's always about, as you said, no, we can't compare, definitely not a global South country, because this and that. But then there were a lot of discussions about the behavior. So that was one thing that I wanted your insight on. The patient, the user behavior, the differences there. That's why we cannot compare. For example, implementation of a certain innovation in country A to country B, because the way it's been adopted, the decision-making cycle, all are different from a social science behavior kind of like lens. So I would really like to know about this and your insight in this, if possible, please.
Well, I completely agree, Mona, and thank you so much for your comment. Absolutely, people's behaviours will be, of course, very different from between one context and another. I think the issue here is that it's not more different just because you're talking about Ghana and not Finland, right? I think that people's behaviour in Finland is also just as different, but we might sloppily think Finland, by being a bit more white or a bit more European feeling or something, there's more similarity. These are, I think, these are falsehoods, in my opinion, that are rooted in this sort of colonial perspective, that somehow the population in Ghana, Malawi, Uganda is just way more different than it is in France. And actually, it's got to be, I think the behavior that you're interested in has to be connected to the population that you're looking at, right? So is there something inherent about, let's say, the French population that makes it more similar on that particular behavior issue that you're interested in to the UK? Well, then fine. But you don't immediately discount that possibility either for, say, Ghana or Malawi. You've got to tie it to the behavior issue that you're interested in. Then that's sort of rational, if you like, in my mind. But just to sort of prematurely arrive at that conclusion just because we're not familiar with it, or because it's a blacker country or whatever, it feels like a mental shortcut that just sort of means we end up missing opportunities all over the place. We sort of continue to treat some countries as other and other countries as similar, and that doesn't seem helpful to me. So I think you're absolutely right that behaviors of people in all cultures are always going to be different from one place to the next, but they're not more different. I think that's the point I'm trying to make.
Thank you, Matt.
Okay, yeah. No, it was really, really, I mean, such a great presentation. Thank you so much, especially because it's so relevant to what I'm researching. Because for me, I come from a communication background, and my whole kind of one of the main reasons why I'm doing my PhD was because I was looking at WHO and United Nations, UNAIDS, kind of like recommendations on how to tackle HIV in the Middle East or North Africa. And I found it to be completely disconnected from the actual countries and the actual beliefs. And that's really the whole process. And that's what I'm looking at, how culture, you need to have a more of a culture-centered approach when it comes to research. And so that's really what my topic is. So this presentation was amazing. It was exactly what I was thinking. But I don't know if this is a question or if you've experienced this, but I've done a lot of kind of I've discussions with healthcare providers in particularly in Libya, because that's where I'm focusing on. And I found that sometimes the restrictions are from the country itself rather than from abroad, in a sense that the government, for example, or the medical professions, they themselves prefer Western, global North advice versus their own advice. And they will always kind of belittle their people because they think that the West and the global North knows better than us. And I think it is changing, but I wanted to understand from your point of view, if you've experienced this, and what would be the strategy or the tactics of how we can change this internally, if possible.
Well, thank you. I mean, I have experienced it, Abia, and thank you very much for your question and reflection. I think it definitely works both ways. I think we, have to reflect on our own, the structuring that happens in the way we're trained and the countries that we pay attention to. I think other countries need to do the same reflection as well. In order to, I'm not saying like radically, sort of throw babies out with bathwaters or anything like that, but just to understand that, there's much more that sort of unites us than divides us on the whole, right? So cultures are equally different, like I said earlier, from each other. So that we shouldn't be sort of creating an unnecessary valence, in this regard. We've got enough problems, right, in the world. But to your point, I have experienced it. So there's something called I've momentarily forgotten the author. Maybe it was Seye Adimbola from BMJ Global Health, who refers to it as northern ventriloquism or western ventriloquism, which is the sort of contorting that that scholars or clinicians or researchers from the global south put themselves through in order to accommodate their research or innovations in the Western lens. To contort their knowledge and experiences in a way that makes it more approachable or, what's the word I'm looking for? Amenable to the Western audience, as opposed to actually just valuing their own knowledges or research in their own way. So, for example, obviously, the high impact factor journals, are all based in the global north, and very difficult for global south researchers to publish in those journals without having a global north author on their papers. So I've experienced, and I understand the logic and rationale of being invited to contribute to a paper because it will help get the paper through all of these difficult barriers that global south researchers that are stacked up against global south researchers in a way that is different, that we experience it differently in the global north, right? Because it's in English, or because we're more familiar, or whatever it might be, or because we're more likely to be able to do that randomized controlled trial that because of the resources we have at our disposal, etc., etc. So I think there's a piece of work that needs to go in both directions there, which is about scholars in the global south really finding ways to also really value their research and not just slavishly sort of pay attention to the global north. We also have to pay attention to us not prematurely discounting research from the global south, give it its due acknowledgement and credence and attention, because there's some amazing research that's out there. We know that, but we're sloppy in where we look for it. So I think there's definitely it's both sides of the same coin, and the reciprocal innovation piece does speak to that much better.
Thanks a bit. Kerry.
Matt, that was great. Thank you. Really enjoyed your presentation. I was wondering what your thoughts are in terms of how much resistance to South-inspired innovation comes at individual levels, and how much comes from institutions, companies, and other organizations. Just thinking about experiences during my career, irrespective of the global north or south. Actually, I remember surgeons reading about the mesh thing for hernias here and thinking, well, that sounds so sensible. but they were unable to adopt because of systems such as procurement, the power of companies, the other things that companies offered, the sort of hidden bribery in a way. And how much comes from individual responses and the biases that you explain that are very hard to avoid, and how much you think comes from these other organizations?
It's a really important question. I mean, Matt knows more than anyone how hard it is, I think, to adopt something from another context, right? So each individual solution I presented and all the others will have its own specific technical, regulatory, commercial, sort of challenges that will need to be addressed and identified, addressed, and then overcome before it can be adopted. And that can take years. So, that's quite a legitimate issue. That's about organizational change and management and changing culture and overcoming regulatory barriers. And those, I think, are perfectly legitimate technical issues. What I think is an illegitimate issue is just the premature discounting of the adoption of that innovation. I don't think all innovations should be just uniformly adopted. Of course, that's not nonsensical, but it should be given its due attention. If there's an evidence base, wherever it's from, and there's a rationale for it potentially to be used, then it should be explored until such point as it's considered not possible to adopt, or there was an appetite, or it doesn't solve a problem that's sufficiently important, or the business case just doesn't stack up. But at least it should be explored. And where I think the problem is right at the beginning, is we don't arrive or provide enough resource to, or galvanize people around the innovations that come in Global South, because we just discount them straight away because they're cheaper or because they're from the Global South. So I think, and we actually, if you like, actually, Kerry, we sort of did quantify. When you ask, well, can you put a figure to the individual issue? Well, kind of. In that randomized control study, there was a 30%, if you like, differential in rating of the research abstracts when it came from a high-income country compared to a low-income country. So you could kind of say that at the individual level, I'm not saying everybody will experience that, but on average, you can actually be rating stuff 30% less well just because it came from a low-income country. So that's one problem. But there are, of course, individuals who see the opportunities and are galvanized and energized to try and translate that opportunity into the UK context. But you're absolutely right that there lacks the institutional, oftentimes in the NHS, the institutional arrangement, system level support to capture that enthusiasm, support that individual translating their experience back into this country in a test bed kind of way, where things can just sort of be explored until such time as they deemed not possible to adopt, but at least to be explored. We find oftentimes volunteers in international health partnerships. I think we may have spoken about this in the past, but they're often sort of mid-career clinicians, still maybe in specialty training, perhaps, who don't then have the institutional, power within their organizations back home to actually adopt the innovations, affect change in the same way that medical directors or chief medical officers or chief procurement officers do within a trust. I'd argue that actually those are the people that ought to be doing the volunteer work in the Global South, because they actually have the position to then affect change back in their own hospital afterwards. So it's a bit of a combination of all of these things, I'm afraid. It's a complex one, and each individual solution will have different problems.
I think also perhaps some of us have failed to do proper research around some of the things that we've heard of and done, and failed to publish. As a lot of us who've worked in the Global South, our skills have been perhaps not in the research field. One example of something that I have always felt a bit guilty that we hadn't sort of done something. We buy in, we do trauma projects fixing fractures, and we buy metalwork implants from India, which are of lower quality than those used in the UK and therefore much cheaper. So that's why we buy them from India. But the lower quality is fine because because they're fractures. They haven't got to last 30 years like an expensive hip replacement or something. They've only got to last really 16 weeks, as long as it takes the fracture to heal, because they're then not load bearing anymore. And what a phenomenal cost difference that would make to the NHS. But we put in, we use Rolls Royces for everything, and we don't differentiate. So, we should do more work really around that kind of thing to publicize it. And yeah, so I think maybe a lot of us have not done enough.
I think there's also a little bit of a disconnect. Are we okay for time, Matt? I'll just make one last point. But a little bit of a disconnect between clinical decision making and affordability for the trust or the system. Now, I'm sort of sit in academia, so it's a bit rich coming from me. But I get the impression that local clinical decision making is not particularly well integrated into questions of affordability at the trust level, let's put it. And so therefore, when solutions become available that might then save significant resources by using those, then there's no mechanism to distribute the savings. We need a sort of a financial modeling or forensic accounting system whereby the value that is obtained from swapping out one piece of technology to another can then be identified and redistributed so that you start to see improvements elsewhere in the system. So I mean, these are complex questions. I don't know the answers to them, to be perfectly honest, but it feels like at the very senior trust executive level, there needs to be maybe a bit of a shift in culture as well in terms of thinking about these sorts of solutions and the opportunities that they can have, not just in that clinical area, but wider. It's not about improving clinical outcomes really anymore. I'm not saying we should never think about improving clinical outcomes, but what I'm saying is I think the real opportunity is in actually keeping clinical outcomes where they are, but at much, much lower cost. The amount of investment that's required, R&D that's required to shift just the marginal improvement in the clinical outcomes we're currently needing or looking for is enormous. Whereas you can maintain the clinical outcomes at such low cost and then distribute those opportunities, those resources elsewhere in the system. For me, I think that's what the beauty of frugal innovation is, what potential of it is that you can do that.
Thank you, Matt, for a fascinating talk and particularly for leading the way in the Healthy webinar series. So thanks for that. And I think I'll just finish on observation, which, where, as I say, I've been fortunate enough to work in Kenya, and I think what I took away from it actually was how similar we are across the health systems, and particularly when you take it from a problem basis. We're facing the same challenges around workforce, demand capacity, and therefore, of course, but it may look different, and I think that's the problem. The environments look different, the people look different, and some of the approaches look different, but they are fundamentally addressing very similar issues at the bottom, and therefore, why wouldn't a solution that's been developed in Kenya or Malawi be applicable in the health back in at home? But it even happens, I go to other trusts and they're facing the same similarities, but the minute you ask them to adopt something that's been proven down the road, it all becomes, oh no, we're special and we need another pilot and another trial. So yeah, the challenges of healthcare adoption. But thank you for your insight. It's been fascinating, and thank you all everyone for attending, and we'll continue to promote the talk as a recording to our colleagues because I think they'll learn a lot from it. So thanks everybody, and thanks again to Matt. Thank you.